Yeah, okay. Thank you very much for the.
Okay, so this session, so webinar, okay, will be presented by myself, Maria Justine, and the second sessions of this webinar will be presented by Mr. Naim Faiz. So our focus is on giving the learning outcomes. By the end of these sessions, you should be able to discuss the importance of exercise, pre-participation health screening, and by the second sessions by Mr. Naim, you should be able to conduct exercise pre-participation health screening. All right, so these are the contents of the first presentations: understanding exercise or physical activity and the importance of pre-participation screening. Among others, we will look at the definitions of exercise and physical activity, prevalence and burdens of physical activity or physical inactivity. What are our roles as physiotherapists in promoting and implementing physical activity? What are the components of physical activity recommendations? We will try to define screening or pre-participation screening. What are the goals of pre-participation screening? What are the updates in the new model of pre-participation screening, and we'll be looking at the components of the screening. Okay, so for introductions, I would like to bring every one of you to revise the meaning of physical activity, exercise, and what are the benefits of physical activity. So I'm sure everyone have learned, okay, during your when you attended your physio school. Physical activity is any bodily movement produced by skeletal muscles that results in energy expenditure, right? Exercise is actually a subset of physical activity defined as planned, structured, and repetitive bodily movement. Okay, so physical activity and exercises results in energy expenditure. Okay, so unlike typical physical activity, exercise that is planned normally done to improve or to maintain one or more components of physical fitness or any of the health goals. Okay, so we know that regular participations in exercise or physical activities will prevent or manage the existence of the lifestyle diseases, okay, or the non-communicable diseases such as stroke, diabetes, cardiovascular diseases, and several types of cancers. Regular physical activity helps to prevent hypertension. It helps us to maintain or manage our body weight, and most importantly, it improves health, mental health, and enhance quality of life and well-being. So regular participations in moderate to vigorous intensity of physical activity will give more benefits to the overall well-being of individuals. So how much physical activity is recommended? Okay, so we are talking about exercise participations or physical activity that is normally done from the moment you are delivered, okay, or from womb to tomb, until you die. Physical activity is very important to maintain your well-being. So for adults aged 18 to 64 and older adults 65 and above, they have similar recommendations where they need to do at least 150 to 300 minutes of moderate intensity aerobic physical activity, or at least 75 to 150 minutes of vigorous intensity aerobic physical activity, and incorporate with strengthening exercises. However, for older adults, because of the aging process and changes in the physiological system, they have to also practice multi-component exercises. Besides doing aerobic and strengthening exercises, you also have to include in the exercise prescriptions balance training and also flexibility training or exercises, because for older adults we need to enhance their functional capacity and we need to prevent falls, because these are declines which is very synonyms to normal aging process. Okay, so we want to know what are the current levels of physical activity among the population, because if we are already achieving recommended dosage by the highest body that govern exercise science or exercise delivery in the world, that is SCSM, okay, we probably don't have to really look at, you know, promoting physical activity, but said to say that, okay, according to WHO, the World Health Organization, in 2021, globally, 1 in 4 adults do not meet the recommended levels of physical activity, and those adolescents, more than 80% is insufficient physical activity. So this figure is similar to the scenario in Malaysia, when about 1 in 4, those 16 years and above, are physically not active. And who are these population who are not active? Majority of them are females. 59% are those aged 75 years and above, and we know the reasons for them being physically inactive. 39% of these population who are inactive are students, and 27% are urban dwellers. So these figures indicate to you that as physiotherapists, we need to target these populations in our interventions. Right. So we know that the level of physical activity globally and in Malaysia are very low, okay, and very high. The physical inactivity, the prevalence is very high, okay, even though it is about 25% from the total populations, but we try to target 100% of participations in regular physical activity. Right, so we know that physical inactivity is actually pandemic because it is affecting global population. So we want to know what are the burden of the pandemic of physical inactivity. According to WHO, people who are insufficiently active have a 20% to 30% increased risk of death compared to people who are sufficiently active. Okay, so when we were to compare the consequences of the COVID pandemic currently, in fact, the burden of the pandemic of physical inactivity is worse than the COVID-19 pandemic, which so far in a year has led to about slightly less than 10% of death. Okay, so the cost of supporting the medical bills of people with diseases associated with physical inactivity cost $billions, right? So we want to know what are the common diseases associated with physical inactivity. All right, so we know that physical inactivity is an independent predictor for the development of many types of non-communicable diseases such as diabetes, hypertension, and high cholesterol in Malaysia. And these non-communicable diseases become the major risk factor for the development of cardiovascular disease, which is the leading cause of death in Malaysia. So, what are other burden of the physical inactivity? Right. So we look at some statistics in Malaysia. Right. So 1 in 5 adults in Malaysia have diabetes. Right. That represent about 3.9 million populations. Okay. So now it's actually we have reached about 18.3% of the total populations of Malaysians suffering from diabetes. We haven't included those with pre-diabetes. Okay, so unlike the prevalence of COVID-19 infections, which the three highest states, Selangor, Kuala Lumpur, and Negeri Sembilan. Okay, so these are the states that is currently having the highest prevalence of COVID-19 infections. For diabetes. Okay, so bad news to those from Negeri Sembilan, Perlis, and Pahang. If you are coming from these states, you have to do something to the state's population. Okay, so in America, for example, in US, they have designed a population-based intervention. For example, targeting. No, this is not an example, but this is what they are doing now in US. Okay, they call it diabetes prevention program. You know, where they target all the populations dealing with weight reductions and adoptions of physical activity by just doing brisk walk. And after a few years, they follow up the participants and they notice that there are about more than 20% have reductions in the measures that they measure during the pre and post test of the intervention. So I hope that physiotherapy is coming from these major these states with the highest prevalence of diabetes. Think of something that you can do for your population. All right, and another issue is the hypertension in Malaysia, in which 3 in 10 of the population in Malaysia is diagnosed with hypertension, especially among males. Okay, and those below 30 years of age, majority are females. Males, you know, males are 3 times more have the possibility of getting hypertension compared to females. So we know that these are the target population. Okay, all right. And cholesterol also, which is one of the characteristics of metabolic syndrome, you know, in Malaysia, 4 in 10 people or 8 million adults, okay, have raised total cholesterol level. So we know that with the aging of the populations, the number also increase, right? And lastly, overweight and obesity and abdominal obesity. Okay, so the statistics by the National Health Mobility Survey found that 50% of adults in Malaysia are either obese or overweight, and 50% are having increased size of the waistline or abdominal obesity. So who are this population? Majority are females, the Indian ethnicity, and for obesity or overweight among those 55 to 59 years old, and for abdominal obesity or adiposity are those among 60 to 64 years old, right? So your intervention should give priority to this group of vulnerable people. All right. So we already know the statistics of people with the burden of physical inactivity. So as a physiotherapist, what are our responsibilities? Okay. So these are included in our scope of practice as a physiotherapist. Okay, we prevent, we cure, we promote, and implement lifestyle interventions. We educate the community, we follow up, we measure them, okay, to give them the importance and to tell them that, look, you are improving or you are getting worse, so what needs to be done, okay. And one of the important modalities for lifestyle intervention is exercise recommendations, okay. So in my presentations, I define exercise recommendation, which include health screening, measures that you learn in physio schools, the prescriptions or the exercise prescriptions that you also learn in school based on the principles of exercise prescriptions that include the Fit Pro, or now according to SCSM is Fit VP, right? As a physiotherapist, you need to identify the barriers to participations in physical activity or exercise, because you need to consult with your clients how to overcome the barriers, right? You need to identify the precautions, the safety measures, and the hazards or the adverse events following the participations of exercises, so that you can either modify the exercises or refer your clients to the physicians, okay? And then recommend your exercise, modify your exercise accordingly, and measure the effectiveness. Right. So as we call ourselves as exercise professionals, okay? So as physiotherapy as exercise professionals, we manage our client consistent with our scope of practice, all right? We enhance the our expertise so that we can identify contraindications to exercise. We know what are the processes involved in the exercise recommendations. That is why you are now attending this webinar, because you want to enhance your expertise, okay? Then we need to, the uniqueness of being a physiotherapist, that when we prescribe exercises, your exercises must be individualized, right? So, so what do we do as exercise professionals, okay? Our target is to decrease the burden on health system, the health fundings, the public fundings, to pay or to support the medical bills of the populations, okay? So we must effectively utilize the skills of or as an exercise professional, and at the same time, the role of a physician to minimize the risk of adverse events during exercises, while at the same time maximize the health benefits through increased exercise uptake and the best practice in exercise recommendations. All right. So before we move on, I would like to highlight to you, okay, that the process, there are a few models available in screening, okay? Remember that the focus of this webinar, before we can prescribe exercises, we want to learn to first screen our participants, all right? Okay, so just to highlight to you, this is what happened in Australia. Okay, this is the model in Australia. They have different types of exercise professionals. So we will look at the qualification and scope of practice of different exercise professions using the Australian context as an example. Okay, so we have the professions, we have the minimum qualifications, and whether these professions have advanced level educations and clinical practicum in exercise prescriptions for pathological conditions, including clinical placement. Okay, and who are their target population for exercise assessment and prescriptions, and whether they can independently deliver exercise to the clients. Okay, so we look at personal trainer and exercise scientist. Okay, So personal trainer in Australia, they have either certificate or diploma or a bachelor's degree, which is not accredited by ESA. Okay, so what is ESA? ESA is the big body in Australia that governs the guidelines or the delivery of exercise in Australia. They look at the syllabus or the curriculum for courses that is undertaking exercise science. Okay, except for physiotherapists, okay, the curriculum by physiotherapists is not governed by ESA, right? Okay, so for personal trainer, they take either certificate or diploma, but it's not accredited by ESA. For exercise scientists, they have a minimum of bachelor's degree in exercise science, which is ESA accredited. Okay, clinical exercise physiologists and physiotherapists, they have a minimum of bachelor's or master's degree in their respective field. Okay, all right. So when we compare advanced level education's clinical practicum in exercise prescription for pathological condition, including clinical placement, personal trainer and exercise scientists, they don't have that opportunity. Okay, but for physiotherapists, remember that during when you were in physio schools, you have to complete a minimum of 1,000 hours of clinical placement that include the ability to prescribe exercises for people with pathological conditions, right? So that is the requirement as stated by the World Confederations of Physical Therapy, right? So now, who are the target population for exercise assessment and prescriptions? For personal trainer and exercise scientists, their scope of practice is only targeted on healthy populations. Unlike the clinical exercise physiologists and physiotherapists, okay, you can see there, clinical exercise physiologists, they have this terminology, clinical, so that probably indicate to you that in their study previously, they also have learned about pathological conditions. Okay, so we as the physiotherapists, we target the healthy populations as well as those with active diseases. All right. So in terms of exercise delivery, okay, in Australia, the personal trainer and the exercise scientist, when they deliver exercises, they need to be supervised by the physiotherapist or the clinical exercise physiologist. Unlike the physiotherapists, we can freely deliver our exercises because we have already considered any contraindications to the conduct of the exercises. Okay, so we do not know yet. Okay, I do not know whether this model, okay, is applicable in Malaysia, but we know for sure that for physiotherapists, yes, this is our scope of practice. All right, so moving on. So now, what is screening? Okay, what is pre-participation health screening? Why do we need to conduct pre-participation screening, and who requires screening? All right, so as I mentioned earlier, I use my terminology, PPS, pre-participation screening, as a short form for physical activity or exercise pre-participation health screening. Okay, so PPE, okay, or pre-participation examinations, pre-participation screenings, sports screenings, pre-participation medical screening are synonymous terms used to describe the process involving the process that participants should complete prior to participation in exercise or physical activity or sports or training or competition, right? So why do you need to do screening? Okay, to identify individuals who may be at elevated risk for exercise-related sudden cardiac death and or acute myocardial infarction. Okay, in sports, why do you do screening? Okay, to decrease the number of sports-related injuries and death by identifying individuals' abnormalities that may predispose an athlete to injuries. Okay, so who are those that require screening? Individuals planning to initiate a moderate to vigorous physical activity that apply to various settings and contexts. Okay, so these are the purpose, okay, and those who require and the definitions of screening in our context. All right. So how do we do screening? Okay. Is there any models that guide us to do the screening? Okay. Remember historically or traditionally those days, few years back, not long ago, we used to use the PAQ, okay? And other places, they use other kinds of questionnaire, all right? The reason being, okay, traditionally in the screening, we need to stratify the risk to cardiovascular events, okay? So all these screenings, okay, required to identify the level of cardiovascular risk to the participations in exercise. Okay, so how do they stratify? Right, so they stratify according to low risk, moderate risk, and high risk. Okay, so if you are found to based on the questionnaire, okay, you are classified as high risk and moderate risk, you will have to undergo many levels of medical examination, subjective history. You have to undergo exercise stress test, ECG, okay? And sometimes the results will give you false positive results, which lead to suddenly stop.
Namara, yeah, we can hear you. All right.
Okay, can you see?
Yeah, coming up.
All right. So what happened when you have to undergo many medical examinations? What happened? Okay. So because of these traditional models of screening, all right, it has shown to be many barriers or limitations in the approach, especially in promoting and implementing the uptake of exercises. Okay. So because of that traditional models, right, they found from their studies. Okay. So SCSM normally they will review the models and also the exercise recommendation every 4 to 5 years. Okay, so you have to read from time to time, okay, about the updates in the exercise recommendations and the exercise screening. Okay, you cannot use those that has been published 10 years ago. Okay, so every 4 to 5 years they will update. So we have to update our reading in order to improve our practice, right? So because of this, they found that there is lack of evidence to support the threshold for recommending medical review. Okay, lack of evidence that medical clearance mitigates risk of cardiovascular events in asymptomatic individuals. All right, so this has become the barriers, the reason why they revise the models. Okay, and the third reason is, to me, is the most important reason, okay? The requirement to seek further medical examination, okay, create a barrier to the uptake of exercises. Why? Because when in US, when you want to undertake moderate to high intensity of exercises, okay, you are required to undergo screening, you know, and they notice that those people who are at disadvantage, they are socio-economically disadvantaged, okay, and yet these are the group of people that is having many chronic diseases and may benefit from regular participations in exercises, but they couldn't afford to pay for the bill for the medical examination. So they don't bother doing physical activity. They don't want to pay for the medical bills. So they notice that this is the major barrier in the physical activity, because medical examination need to be done by the physicians and you have to pay for the bill, right? So similarly, previously in Malaysia, okay, especially those with chronic conditions or maybe suspected or with symptoms of cardiovascular disorder, they are also required to go for stress test, ECG, and this is costly, right? So this is another main reason why they updated the models, okay? And again, the fourth reason why they revised the model is what is happening in US, you know. I'm not sure about in Malaysia. Okay, so many medical schools curricula or syllabus in US do not address exercise screening and prescriptions in detail, unlike training for exercise professionals. Okay, so the physicians may not be familiar with exercise guidelines. They may be ill-equipped to provide clearance or the specific advice to offer the exercise parameters. Okay, the Fit Pro. When they do office assessment, they do it within 15 minutes or less, and in the absence of assessment of the response to exercise. Okay, so I think based on my experience, you know, working with doctors previously when I was in practice, the doctors, they tend to tell the clients that, okay, please go back and do exercise, you walk you know, half an hour a day, but they don't have a proper guidelines. They don't give a proper guidelines in terms of the principles of exercise prescriptions, and they are not aware of the principles of training, unlike our physiotherapists in the curricula in our physiotherapy study in Malaysia. I hope so. Okay, so the new model. Okay, so now because of the outdated models in screening, okay, so SCSM has come up with a new model, right? So the goals of the new model are to identify individuals who should receive medical clearance before participating in exercise or before they increase the dosage of the exercises. To identify with individuals with clinically significant disease or diseases who may benefit from participating in a medically supervised exercise program. So remember, the second goal is very much within the scope of physiotherapies, because the exercises for people with certain condition need to be individualized. Okay, and the third goals of the new models are to identify individuals with medical conditions that may require exclusion from exercise programs until those conditions are abated or better controlled. Again, physiotherapists has actually a major role. Even your clients are being excluded from certain exercise programs, but you know that you need to maintain their functions for them to continue on doing their activities of daily living. Again, I said here, the program, okay, not necessary that your exercises is at moderate to high intensity of aerobic physical activity, but you can do some functional exercises to your clients that may be excluded from this dosage of exercise. All right, so the new model, okay, of the health screening focus on the current level of physical activity and the presence of signs and symptoms of cardiovascular, metabolic, or renal disease, and the desired exercise intensity, as these variables, remember that has been identified as risk modulators of event exercise response to cardiovascular events. Okay, so if you remember the previous model, the traditional model, okay, if you were to revise the questionnaire, they also include pulmonary disease, okay, but the new model, they found that actually for any clients or people with pulmonary disorders, it is safe for them to continue with moderate to high intensity of exercises. All right, so this is what I found in Armstrong et al. 2018. They compare the previous updated ACSM. Okay, so look at this, the old one and the new one. Okay, the new one, they have added the current level of physical activity. All right, so the old one, okay, they look at the number of CVD risk factors that include age, body weight, cholesterol, and few other risk factors, okay, and they look at presence of signs and symptoms of CVD and non-CVD metabolic, renal, or pulmonary diseases, okay. So the new one, they have added level of physical activity, whether you are currently doing any physical activity or no. Okay, when you are asking your clients about physical activity, you must define what is the recommended level of physical activity, right? Okay, so again, the new model also look at presence of signs and symptoms of CVD. They look at non-CVD, metabolic, or renal disease. Okay, so this is the difference here. They don't ask anymore about pulmonary disease. Okay, and what is your desire in terms of intensity for you to do exercises, whether you want to start low, moderate, or high intensity. Okay, so now I have introduced to you a few models. Okay, again, we go back to which models or guidelines for physiotherapists to use for conducting PPS in Malaysia, right? So I have introduced to you the ESA, okay? In fact, the ESA, they have the guidelines and they have the forms, okay? But I don't intend to discuss the guidelines for ESA to screen, okay? But I really love the guidelines produced by ESA because but however in Malaysia, because we are already using PAQ Plus and the SCSM for some times, you know, and in the university we teach PAQ. Okay, now we teach PAQ Plus, the updated one. Okay, in my university, okay, it is a must. Okay, if you are conducting a research, okay, when you are applying for ethics, research ethics approval involving human subjects, okay, when your research has the element of testing physical fitness, okay, and your physical testing is a very new technique, and if you are giving interventions, exercise interventions to your participants, and especially at moderate to high intensity involving vulnerable subjects like pediatrics and geriatric populations, mentally challenged populations, and other ethnicity, okay, you have to include health screening in your proposal. That is at least a PAQ Plus or the SCSM new algorithm. Okay, now because we have to use the new algorithm. So those of you who is about to conduct your study to apply for ethics approval, don't forget to include your PAQ Plus in the methodology of your study. All right. So, however, okay, so before that, I would like to bring you back to the recommendation by ESSA, okay? So remember ESSA, Exercise and Sports Science Australia, okay? So this is how it works in Australia, okay? So clients can be referred by anybody, right? You can refer yourself to go and see the personal trainer or the exercise scientist or the physiotherapist or the clinical exercise physiology. All right. So, all right, the physician, other health professionals, case manager, or your employer actually can refer you to go and see the physiotherapist. Okay. For example, if you are an employer to your employees and you see that you have to see the nature of work, and can you just record their body mass index, body weight, height, body mass index, and also their waist circumference, the beginning of when they start working with you, and follow up every 3 or 6 months. Okay, if you have a decline or worsening of these anthropometry and body compositions factors, they may need to be referred to the exercise professionals. Okay, so exercise scientists, remember the table 1 just now, exercise scientists and personal trainer, they do screening, okay, based on the ESSA questionnaire, okay, and is exercise prescription within scope of practice. All right, so the scope of practice is among healthy populations. Okay, if yes, then they can prescribe exercises safely, okay, and encourage their clients to continue their exercises. But if the clients are not within the scope of practice, okay, because the clients may present with chronic disease, okay, so in Australia, they need to be referred to the clinical exercise physiologist or the physiotherapist, because the physiotherapist will do additional medical history and physical assessment, right? Why? To detect any adverse sign or symptoms. If there is no adverse sign or symptoms, so you can continue prescribing exercises to your clients. If there is any signs or symptoms, then they need to be referred to the physicians, okay? And as a physiotherapist, all right, or exercise professional, you need to learn how to identify adverse sign or symptoms due to the participations in the exercise. Okay, so this is PACU Plus, okay, the questionnaire. It is lengthy, but it's actually very fast. It's very simple, it's very fast, okay, but I'm not gonna describe to you PACU Plus because this will be covered in the second sessions of the webinar, right? So it has, if you remember the old one, PACU, okay, it's only 1 page, it's only 1 page, but the updated one is 4 pages, right? Okay, so that is PACU Plus, and the algorithm or the new algorithm or model of screening by ACSM. Remember that one of the new item in the screening is to look at the level of exercise, whether they are using, they are currently doing regular exercises, yes or no. Okay, then you have to follow this algorithm. Okay, so what I advise our physiotherapists is to know about PACU Plus and to use this algorithm when screening your clients. Okay, if the latest book edited book by SSM is actually recommending the use of PACU Plus and this algorithm. All right, okay. So we are almost to the end of my introductions to health screening prior to exercises. Okay, so what we have learned here, to answer the purpose of the international webinar series in the best practices in physiotherapy management. Okay, so I am now recommending to you what is the best practice in exercise recommendations for our clients. Okay, so first you need to do PACU plus, right? And you also need to do the exercise screening algorithm, right? And then as a physiotherapist, remember that what we learn in school, the many types of physical examinations according to the to the client's conditions. If they present with musculoskeletal disorders, okay, for example, like low back pain or osteoarthritis of the knee, okay, and they want to participate in physical activity or exercises at moderate to high intensity of aerobic exercises to prevent non-communicable diseases, because these people, when they have this problem, they reduce their physical activity, all right, and they develop non-communicable diseases, right? So you have to choose what is the best outcome measure or tools that you can follow up after sometimes after you recommend the exercises in MS, in cardiorespiratory, in geriatrics, for example. Balance assessment need to be included, because remember that for older adults, your exercise prescription must be multi-component, right? And in patients, clients with neurological conditions, okay, so you know what are the outcome measures that you can include in the best practice in your exercise recommendations. And the exercise prescriptions need to be individualized, meaning that you cannot have one recipe for everybody, all right? And you should be able to identify the adverse events for the cessations of exercises or for the modifications of your exercise prescriptions. And all this must be supported with clinical reasoning and ongoing learning in understanding exercise recommendations. Okay, so as a conclusion, we know that insufficient physical activity is a burden to the healthcare fundings, right? So it's very costly to pay the medical bills for populations with the many types of diseases, as I presented to you earlier, what is happening in Malaysia. Okay, so physiotherapists are exercise professionals that are educated, that can encourage or motivate the participation in physical activity based on safe guidelines and effective dosage of physical activity. So as professionals, we need to collaborate with the physicians to improve the uptake and maintenance of safe and effective exercises. We need to do exercise screening for those with and without chronic disease based on the updated or contemporary guidelines or models or algorithms or questionnaires. And why? Because we need to prevent certain hazards, you know, adverse events or hazards of physical activity or exercise related cardiovascular events can be reduced by safe and effective exercise prescriptions. Okay, so all right, so recap what we have learned during my presentation. We are now able to define exercise, physical activity. We know the prevalence of lack of physical activity and what are the burden of physical inactivity, and how can we promote uptake in physical activity, and the importance of screening prior to participations of exercises. And as a physiotherapist, we have now learned the scope of our practice in exercise recommendation, especially in exercise assessment and delivery. All right, so the last outcome, can you conduct screening now? Not yet, because you will be guided later on in the second sessions of this webinar. Okay, so thank you very much. These are the references. And if you were to start exercises for your clients, because as physiotherapists, most of our clients came to us with pathological condition. It is always safe to start low and go slow, okay? Because evidence has shown, sorry, my voice is, all right. Okay, so evidence has shown that participation or abrupt participation in high intensity of exercises can lead to many adverse events, and also it discourages long-term adherence to exercise participations. Okay, so thank you very much. If you were to ask if you want to communicate with me, you can email to me. And the presentations will be uploaded in the YouTube, okay? You can check physiotherapy in exercise rehabilitations, but probably later on, all right? So thank you again.